Hello all, and welcome to our PSY2ACH oral presentation. This presentation was created by Ben, Emma, Kai, Olivia, Talisa, and Zahra. Here's a list of our delegated tasks. Our client today is Chris Harris, a 20-year-old male born in Australia. He never worked throughout school and unfortunately was frequently bullied. Chris experienced his first panic attack during his HSC examinations. He found this to be extremely humiliating and became worried that he would have another one in his future examinations. He also began feeling highly anxious on public transport. He had never felt this way prior to his first episode. Since his graduation, Chris has been attempting to get a job, but has failed, for whenever he attends an interview, he experiences an overwhelming fear that he will have a panic attack, like he did during the exam. His first session with a psychologist identified the following fears: enclosed public spaces with no easily accessible exit route, anxiety relating to public transport, quiet, formal settings in which odd behaviour will be easily noticed or questioned, and situations that require a presence of comparison. The following video is a role-play scenario of Chris's second session with his psychologist.
Hey Chris, it's great to see you again. How are you doing?
Yeah, I'm doing okay, thanks.
That's great. How did you feel after our first session?
It was really good to get things off my chest. I felt like I was finally getting some clarity about why I feel this way.
That's fantastic. And I'd like to expand upon that in this session, if that's okay with you.
Yeah, that sounds good.
So we've uncovered that you have a sense of fear and anxiety when you're in these enclosed spaces.
Yeah, I just feel like I can't escape.
So what do you feel like you can't escape from, Chris?
I just feel like I'm going to freak out like I did in the exam. I start to feel sick. Sometimes when it gets really bad, I feel like I'm having a heart attack. I just try to stay at home and not use public transport. I don't want to get caught in that situation again.
So do you have these feelings when you go anywhere else, like outside for a walk?
Yeah, I'm starting to avoid going out unless I'm with a friend. It gets worse the more I go for job interviews, and I try to bring someone with me, but they obviously can't come into the actual interviews.
Yeah. Do you get these feelings before a job interview or while you're in the interview?
I've only ever had one episode in an interview, and then the other interviews I've just tried to attend, but I freak out before I go into them. I end up cancelling because I'm so afraid that I'll humiliate myself again. I just don't want to faint or have a heart attack. It would be so embarrassing.
So how long have the episodes been going on for, Chris?
Since my first exam 2 years ago, it started with me like not being able to go onto the bus. But over the last 6 months, it happens every time I go for a job interview.
That must feel very overwhelming for you. The good news is we can definitely work towards getting you back to feeling normal again.
Really?
Absolutely. So what you're experiencing is known as a panic attack. The symptoms that you're experiencing, such as feeling dizzy, your heart racing, nausea, and the heart attack feeling, is basically your body getting ready for fight or flight mode, and when there's actually no danger there. So what we'll work on is developing coping mechanisms so that you know how to deal with them. There are quite a number of techniques and methods we can work together. So if one doesn't work, we can always try the others and see if something else fits.
Yeah, that makes sense. It's so good to know that what I'm going through isn't just all in my head.
Absolutely. And while your disorder is more common in females, it actually affects about 5% of the Australian population. So it's more common than you think.
So what kind of things can help? I mean, I don't know how to feel about drugs.
Well, we can try cognitive behavioural therapy. It focuses on techniques such as relaxation and stress and anxiety management. We can also try graded exposure, which works up to like a guided exposure of your anxiety-provoking situations.
I don't really like the sound of that last one.
Yeah, well, we do work in small steps towards it. So you'll learn techniques to help you cope before any of that exposure. And it's a gradual process. And of course, I'll be here helping you along the way.
Is there anything else?
We can also try medication-based treatment to help with your anxiety, but we'll only use that as a last resort. It's just another tool we have if needed.
Well, thank you. That makes so much sense.
You're welcome. And are you ready to learn some starting techniques now?
Yeah, let's go for it.
Great.
So, can you guess the disorder in which Chris is presenting with?
Did you guess the panic disorder agoraphobia? We're not experts, but in our clinical judgment, Chris meets the DSM-5 criteria. There are 8 criterion. A. People presenting with agoraphobia need to show marked fear or anxiety about 2 or more of the criterion situations. Chris presents with at least 3 of these, showing marked fear and anxiety about using public transportation, being outside of the home alone, and being in enclosed places. B. Chris avoids these situations because he fears that he cannot escape in the event of experiencing panic-like symptoms and other embarrassing symptoms such as nausea, dizziness, sweating, etc. C. These situations for Chris almost always provoke fear or anxiety. D. Chris actively avoids the situations that cause him anxiety unless he can bring a friend or he endures them with intense fear or anxiety. E. Chris's fear and anxiety, particularly of a heart attack, is out of proportion to the danger of the situation, such as attending an interview and transportation. F. Chris's anxiety, in particular the panic attacks, have been present for more than 2 years. His avoidance has lasted for more than 6 months. G. Chris's fear, anxiety and avoidance causes clinically significant distress or impairment in social, occupational or other important areas of functioning, particularly getting a job and now leaving the house. H. Chris does not have any physiological medical conditions which could explain the avoidance. I. While Chris's fears and anxiety share similarities with other mental disorders, there are specific reasons to why he presents with agoraphobia. These are presented on the next slide.
Social anxiety is similar to agoraphobia in the way that the sufferer is worried about what others will think of their anxiety symptoms. However, they differ as social anxiety is characterised as the fear of social situations, whereas agoraphobia fears that there is no escape, fear of open and enclosed spaces. OCD is similar to agoraphobia because there is the presence of intrusive thoughts that cause anxiety. They differ as OCD sufferers attempt to suppress the thoughts using compulsive behaviour, while people with agoraphobia avoid the situations to reduce anxiety. Agoraphobia and the situational type of specific phobias are similar as situations that provoke fear, anxiety symptoms are actively avoided. The fear and anxiety and avoidance can last for 6 months or more, and because both disorders experience clinically significant distress or impairment in social, occupational or other areas of functioning. They do, however, differ as a specific phobia will be restricted to a fear of only one of the agoraphobic situations. Someone with agoraphobia will have 2 or more fears from the list of agoraphobic situations, and will fear both the situation and the panic symptoms. Agoraphobia and post-traumatic stress disorder are similar as both avoided stimuli associated with traumatic events, for example, situations that may cause distressing thoughts and feelings. They differ as PTSD is a fear of the actual situation itself and the feelings, thoughts and memories that come of it. Agoraphobia fears that there is no escape and also have a fear of the embarrassment. Separation anxiety and agoraphobia are similar as both disorders require or prefer the presence of a companion. The main difference between the two is that separation anxiety disorder doesn't have a fear of no escape or embarrassment, but focuses more on having a major attachment figure with them at all times, worries that something might happen to said attachment figure, and having nightmares of separation themes.
Multiple therapy-based techniques are available for Chris in the next steps towards his treatment, starting with cognitive behavioural therapy, commonly known as CBT. Through cognitive behavioural therapy, Chris will become familiar with the situations in which his specific anxiety-evoking thoughts occur and also learn stress management and relaxation techniques in response to those situations. Graded exposure is the second therapy-based technique that will be recommended to Chris, which involves gradually reintroducing the client to the feared stimulus. This is performed by first imagining the feared stimulus and then working towards guided exposure of the most feared real-life situations. This is done whilst employing stress management and relaxation techniques to become more familiar with the feared situations. Coping mechanisms can also be utilised during the time in which Chris is completing his CBT and/or graded exposure treatment. Coping mechanisms such as breathing exercises, which focus on slowing down the rate of breathing, progressive muscle relaxation, where the client may slowly release tension built up in the body, and grounding, which is making conscious note of the world around you by recalling what you see, hear, smell, and feel in the current situation. Medication-based treatment, including the possible prescription of a selective serotonin reuptake inhibitors, commonly known as SSRIs, could be used in alleviating Chris's daily anxiety. Sertraline or fluoxetine are common examples of SSRIs which increase the level of serotonin available in the brain by inhibiting the reuptake of the serotonin. A PRN could also be administered to Chris, which infers to be used when necessary. Medications such as benzodiazepines are great to be used as a quick but short-term fix for negative episodes, but prescriptions of these medications is only sometimes applicable as anti-anxiety medications can be very habit-forming. Although fine in Chris's case, these types of medications should not be prescribed to patients with evidence of long-term problems with anxiety, alcohol, or drug abuse.
Thank you all very much for listening. Hopefully you found this information to be interesting, and congratulations to those that were able to correctly guess the disorder. If you have any questions regarding our presentation, please ask them now.